Good day. We're live from UCLA Medical Center, and I'm happy to be here with you this morning. I'm going to go ahead and advance the slide. Good day. My name is Dr. Nick Shamie. I'm a professor-in-chief of orthopedic spine surgery at UCLA. And today I'll be talking with you about new surgical techniques in spine surgery. I welcome you to this webcast, and I urge you to forward any questions you have to us at #UCLAMDChat, as seen on the screen here. So I would love to have this as an interactive exchange where your questions will be answered at the end of this presentation. So first I wanted to try to explain to you how spine surgery has really evolved in the last several decades. Such that spine surgery is no longer something you need to fear. Although spine surgery is the treatment of last resort for most people with neck and back problems, if you do end up needing spine surgery has really become a very safe and controlled procedure that can get you back to your life. In many cases, patients come to my office fearful of having spine surgery because they have seen someone in their neighborhood or a friend who had spine surgery who was debilitated, and this patient has been suffering with pain for 2 years, not wanting to come to see a spine surgeon because of that fear. And what I explained to that patient is, well, bad news travels faster than good news. You always hear about the person who is on their way home who gets in the car accident and never makes it home. But you don't hear about millions of people who are making it safely to their house. Same thing with spine surgery. I think you always see the bad results. But I can tell you that from my over a decade experience at UCLA, with the over 1,000 cases that we perform at UCLA a year on patients with spinal disorders, we have achieved a top 3 ranking as far as safety, readmission rates, infection rates for our patients, and we're very proud of that result. And that comes from a lot of things, dedicated colleagues that I have at UCLA and staff that we have in our hospitals, but also advancement of technology, which has allowed us to offer this tremendous improved quality for our patients. So if you have pain, please listen carefully because there may be some options available for you. And don't be fearful. Just go and get expert advice wherever you are in the world. And I also put some bullet points there that our understanding of pathology with all the imaging technologies, with the MRIs, X-rays, and advanced technologies that we have has allowed us to better diagnose patients, which is the key factor in providing the best treatment and outcome for our patients. Let me just start by reviewing the basic anatomy that leads us, when it's not normal, to problems in the spine. So on the left side of the screen, you see a picture of a spine, or the segments of the spine. These segments in general are present all the way from the base of the head all the way to the bottom of the spine at the waistline. What I mean by that is you have these vertebrae on top of each other with the intervening discs. I'm sure you've heard of herniated discs. These are the structures between the bones at every level of the spine, in the neck or the lower back, which is more commonly where the problems are, where these bones are sitting on top of each other between the discs, between them having these discs. I always use the analogy of a spine as a 3-legged stool. The front leg is the disc, and there are also 2 legs in the back that we can't forget about. These are called the facet joints, and there's one on each side, and when the spine eventually, as we age, degenerates, these discs shrink down, and these joints also see more force, and they can get arthritic and start getting larger, putting pressure on the nerves that are exiting in this area. So the vertebrae are sitting on top of each other with the disc and the facet joints in the back. These joints are present throughout the spine. And as the disc degenerates, the hole gets smaller, the disc can bulge out, cause pressure on the nerves. You can also have fractures in the bone called spondylolysis, where the spine can then be unstable and slide forward. I'll show you some examples of that. But more commonly what happens, it happens in everybody, these discs degenerate. And in some people, especially if they're born with less room for the nerves, this additional collapse of the space for the nerves will cause nerve pain from pressure on the nerves. In a younger age where this disc is still very aqueous or has a high water content in 30s and 40s, that the disc, which is similar to what a jelly donut looks like, can have a problem where the jelly can squirt out outside the boundaries of the disc, and that piece of disc can push and lodge in here where the nerves are and cause what's called sciatica or disc herniation. So those are the things that happen in the spine along with other things. You can have infections, you can have tumors go into the spine, but in general, the problems that we see in our offices is due to wear and tear in the spine or a disc herniation of some sort. So those are the common things that we see. And this is a cross section of the spine. So this is a side view of the spine, another side view showing the nerve actually exiting in that hole. But this is a cross section. If you were to slice the spine, you would look at it from the top, and this is what you would see. The disc is in the front. Here are the sac of nerves that is present in the lower lumbar spine. And you can have a disc herniation that then pushes on these nerves that are going up and down the spine, causing shooting pain down the legs, sciatica. Or if it's in the neck, it can cause shooting pain down the arms. We'll talk about issues with the neck also that causes that shooting pain and how we treat it a little later. But generally speaking, the nerves, when they get pressed either from the disc or the joints that we talked about, the facet joints here, if they get bigger or if they get cysts inside this joint, that can all cause this space for the nerves to shrink down, or the cyst or the disc can put pressure on the nerves, causing the pain to go down the legs or the arm. In severe cases, there could be so much pressure on these nerves, especially if it happens in the neck or upper part of the spine, where the patients can lose their balance or dexterity, and they can have problems functioning with the nerves going to the arms and the legs. So in severe cases, that can also happen. It's called myelopathy, where there's pressure on the spinal cord. But in general, that's a more rare condition that we won't get into too much. But if we were to generally classify the types of surgeries that we do for patients with some of the problems that I discussed earlier, there's two main classifications of surgeries that we do. One is decompression, the other is fusion. So in general, we do decompression surgeries when there's pressure on the nerves, as I explained earlier. So we identify where the pressure is, we correlate the pressure with the area of the symptoms, and if there's a correlation, and if the patient has failed to get better with conservative measures like physical therapy or non-surgical measures like physical therapy, medications, sometimes even injections, then we can resort to surgical treatment, which is decompression, to relieve that nerve. Sometimes it's not just the nerve that's being compressed. There's also a problem with the stability of the spine. You can have a break in the back of the spine. You can have such bad wear and tear that has made the spine unstable. When the vertebra, as I showed you earlier, can become unstable, that could put pressure on the nerves. And in some of those cases, we have to do what's called a fusion, where we stabilize the one vertebra against the other ones by putting screws or various different types of implants to stabilize that spine. And that's what you've heard of, I'm sure, about when you think about spine surgery, what fusion means. Sometimes we only do decompression alone, and sometimes we do the fusion alone for various different problems. But oftentimes we combine the two together. So a patient may have instability, on top of that have nerve compression. So not only we have to do decompression for that patient, we do fusion. This is one of the common things that happen. I'm showing you an MRI of a patient with a large disc herniation. Now that you've seen the cartoon image of what this spine looks like, this is an MRI, actual patient MRI, where these bones and the discs are sitting on top of each other. In this case, though, you see that disc that's normally contained between the bones is bulging out. And this is the nerve sac back here. This is, again, a side view of the spine, center cut. And you can see this huge disc herniation. The jelly that's normally present in the center of the disc has herniated out and has come out into the canal where the nerves are going through. And this patient would undoubtedly have significant pain going down their legs. In severe cases, their bladder and bowel function could be also affected, which becomes an emergency surgery type of a situation. Oftentimes, the bladder and bowels are not affected, but the reason they can be affected is because the nerves that control the bladder and bowels also pass through this area. So there could be so much pressure on these nerves that the control of the bladder or bowels could also be affected. You can have weakness, but oftentimes and more commonly, patients come in with severe lancinating pain down their legs or down through the buttocks to the legs, and that's the problem of a disc herniation. Again, most of these patients don't need surgery. We evaluate these patients, and oftentimes we send patients for some type of a treatment, whether it be physical therapy or epidural injection or give them medication. And most patients with this problem get better without surgery. But when the surgery is needed, I don't want to gross you guys out who are not inclined to look at these things. So please close your eyes if you get sick when you see real live pictures. But I thought it would be interesting to show you what a disc material looks like. It pretty much looks like crab meat. And this material could be pushing right against your nerve and could cause severe pain. And we can take the disc out and relieve the pressure from the nerve. And I mentioned to you about spinal fusion. This is a cartoon image showing where you could have a crack or a fracture or spondylolysis in the back of the spine, which all mean the same thing. And that could result in instability, where this one vertebra slides forward, or it can go backwards too. But in this case, the spine is moving forward and causing a pinching of the nerve situation here. In this patient, if the patient becomes symptomatic and we have to relieve the pressure of the nerve off the nerve, which is the decompression that we talked about earlier, in this case, we would also have to fuse the spine to stabilize that patient. Because if we just relieve the pressure off the nerve and leave the spine unfused, then this instability situation can get worse and will cause more pressure on the nerves, and it's more difficult to treat the spine once it's slipped forward even further. So it's easier to treat these patients earlier on than later. So this is what a fusion looks like in the lower back, where we put these implants, titanium screws, carefully inside these bones, and once we put the screws in, we connect them with the rod, and we have these set screws that screws down the rod into the pedicle screw and fixates the spine. And we can do this in one level where one disc is fused, or we can do it in multiple levels when needed. This is a implant that we can also put between the bones, because once we take the disc out, we don't want the vertebra to collapse on itself. So we have ability to put implants between the bones to help with the fusion between the bones, so this patient's spine becomes stable enough. This is an MRI of a side view of a patient's neck. You can see the same kind of a problem that we saw in the lower back can happen in the neck, where the discs in this case are bulging out. There's also bulging from the ligaments in the back of the spine, and here we have a situation where the spinal cord, which has plenty of room here, the white being the fluid that bathes the spinal cord, is diminished in this area. And this area, in multiple levels, this patient has significant pressure on the nerves, or on the spinal cord. In this patient, they could have dexterity problem, walking problems, shooting pain down the arms. Different patients present differently, so it's important for the surgeon or the doctor who's evaluating a patient to make proper diagnosis, and which leads to the proper treatment. So in this patient, with this significant compression on their spinal cord, they had problems with their spinal cord function. And this is, again, a cross-section or axial image showing you the same thing, how the spinal cord, which is shown here, is being pressed by this disc and bone that is pushing on it. and there's no room around the spinal cord, and the spinal cord is being compressed. The nerve pressure is one analogy that I use so patients can understand what it feels like. One simple example is when you're lying in bed and you wake up in the middle of the night and you can't move your arm, is because of the lying on that arm that causes really a temporary malfunction of the nerve from poor blood flow to that nerve and also pressure on the nerve. And imagine lying on your arm, not being able to move it, and not being able to move the arm or move the disc away from the spinal cord to relieve that pressure. That's how it feels when patients come in with these significant pressures on their spinal cord. This is that patient that we went in and opened up the back of the neck. These are all different, what's called lamina, or the back of the spine. This is the spinous processes, the little bump that you feel in the middle of the back of the spine. We open that up and we're going to cut the lamina. It's called laminoplasty, where we actually create more space for the spinal cord. It's called laminoplasty because we're really doing plastic surgery on the lamina and making it wider and open up for the space for the spinal cord. You see these bones, there are various different techniques to hold this lamina apart once we open it. This is a technique that I used before, where we put bone graft and we actually put sutures. And the spinal cord is actually underneath these bone graft. So this spinal cord that was being compressed from the back is now relieved of the pressure, and it's allowed to move away from those discs that were pushing on it, relieving the symptoms. There's another x-ray of a patient with multiple level pressure on their spinal cord. And in this case, there are big bulges of discs pushing on the spinal cord. Again, the side view of the neck with the spinal cord coming down, with the bones and the discs in the middle. You can see these three bulges right here, putting pressure on the spinal cord at multiple levels. And what we did for this patient is remove the bone and the discs in these areas to free up the spinal cord. This is just showing you a patient lying on an operating room table. We have draped out the areas that we're going to be operating on. This is the neck of the patient. And we're going to be going anteriorly, or from the front, to expose the front of the spine so we can relieve the pressure from the spinal cord from the front. But the reason the pelvic area is exposed is because the pelvic area is where we can take the bone graft. Oftentimes when we are doing fusion surgeries, we may need to use bone graft from the pelvis. I use that a lot less frequently now because we have so many new adjuvants or adjuncts to local bone that we can take from the spine, that we don't oftentimes need to go to the pelvis anymore for bone. That was a source of pain longer than the surgical area for many of my patients for years. And with the new technologies that we have to substitute that bone from the pelvis, the post-operative course has become much less painful for patients because we don't have to take bone from the pelvis anymore. But this is a picture of the front of the neck with the piece of bone that we took from the iliac crest with a plate in the front holding the spine in place. And this is an x-ray of that same patient. The bone graft is here. This is after a couple of years where the bone has become solid against the patient's own vertebra with a plate in place. We don't remove these plates. They stay in place, even though in this case, because there's a solid fusion, the patient doesn't need that plate anymore. In order for us to remove that plate, we have to do another surgery, which is unnecessary. And patients don't feel this plate, and so we leave it in. There's another image of a patient who has a slippage, and you can see the back of these vertebrae are lining up. This is a lower back now we're looking at, and this vertebra is slid forward in relation to the other one, and the nerves in this case were being pinched, so the patient has back pain and leg pain. So what do we do to recreate what this patient has up here, which is normal? We have a nice disc space on this x-ray with the back of the bones lining up. So what we really have to do is put a spacer in the middle here to jack up this height, and also put some screws in the back to stabilize the spine so it doesn't slide forward anymore and fuses in that position. And that's what we did here. You can see actually the bone graft with the spacer recreating that space between the vertebra, and these screws that I showed you a cartoon image of that stabilizes that bone. And this is the more live intraoperative image of that same patient. Believe it or not, these patients recover quite quickly from this. And as invasive as this look, with a nerve sac in the middle, with the screws and the bone graft on the side, these patients, once we close them up, within 2 to 3 weeks, the patients are significantly better than what they were before, with that lancinating buttock and leg pain gone. With minimal back pain at that point even. So this is the nerve sac, and we have removed the bone that was pushing on the nerve, reduced or brought back the bone that was slid forward, and put these screws in to stabilize it with these rods. And this nerve sac is very thin, and in about 5 to 10% of the cases, you can have a small leak in that nerve sac. It's filled with cerebrospinal fluid under pressure. And when that happens, we repair the dura to keep the fluid inside. And usually, the long term, there's no consequences from that tear if it happens. And the patient recovers well from this. So, the next thing I want to talk to you about, I've talked to you some of the traditional surgeries that we continue doing for patients who need those big open surgeries. But in some cases, the problems are not in multiple levels or in smaller areas of the spine. And with a better diagnostic techniques, we're able to treat patients with less invasive surgery because we have defined a more focused area where the problem's coming from. And really, the concept of minimally invasive surgery is not a new concept, but a lot of times we hear about these on the internet and news releases, but there's really no defined way we can talk about minimally invasive surgery. But in a general sense, if we want to define minimally invasive surgery, it's basically less invasive or less surgery for the same results. But that's the catch, because a lot of times when surgeons are focused on doing less invasive surgery, working through smaller holes or smaller incisions, they don't address the bigger problem that exists. So in some cases, really, when you do minimally invasive surgery, you're not doing service to the patient. You're just really trying to use that new technology through the small tube. So what I always say is minimally invasive surgery should not equate to minimal treatment for the patient. We first have to define the problem and make sure that we can treat patients with less invasive surgeries and minimally invasive surgery. But I'm going to present to you a few cases or a few techniques that I use for my patients when they are candidates for these minimally invasive techniques. And in general, minimally invasive surgeries will result in a quicker recovery for the patient if we use it for the right type of a patient. And because it's a smaller surgery, quicker recovery, and less damage to the surrounding tissues. So this is an example of that same big surgery that you saw. If a patient is a candidate for it, we can do these screws through small stab holes. Instead of making a big incision in the middle of the back, splitting the muscles open, which can cause a few weeks of pain and recovery with higher risk of infection, we can do these surgeries through smaller holes. But in order for us to not see the spine and put the screws correctly in the spine, we need live navigation intraoperatively. And with the advent of new technologies, we have navigation, we have live x-rays in the OR, as I'll show you in this next slide, which can allow us to do this for the patients. Because if we don't see inside the spine and use anatomic landmarks, we have to be able to see through the skin and the muscles somehow, and we do that through these navigational tools. Few conditions that I wanted to talk to you about in relation to the new technologies that we have to, or techniques that we have to treat patients. One common problem that we see is lumbar stenosis. Lumbar stenosis basically is pressure on the nerves in the lower back. We've talked about those pressures already, what causes it, those joints, the disc bulging. It's a very common problem because as our spine ages, everyone will have degeneration in their spine. It's difficult to sometimes identify who with that degenerative spine on their MRI is truly symptomatic from it. So we have to be very careful about interpreting MRIs, but oftentimes when patients come to my office with these horrible looking degeneration of their spine with pressure on their nerves, they are suffering from a condition called lumbar stenosis, or pressure on the nerves in the lower back. It's a very common problem. 2.5 million Americans are affected. It's the most common reason why we do spine surgery in the United States and probably in the world. And with the baby boomers getting older and older, 60s, 70s, which is this problem of lumbar stenosis more common in, we are seeing more patients with lumbar stenosis in our patients. What do we do traditionally for these patients? Well, if there's pressure on the nerves, we do discectomies, we do laminectomies, sometimes we do a fusion. But if we can identify as 1 or 2 level where the problem is, can we treat patients less invasively? One of the classic things that we hear from patients with lumbar stenosis is when patients with lumbar stenosis are upright, they have this severe buttock and leg pain. But when you sit down or when you lean over a shopping cart, we call that actually shopping cart sign in our books, that relieves the pressure. The reason for that is the spine, when you sit down or when you lean forward, you're flexing the spine. So if this is the back of the spine where those little bumps are, I'll show you in a second, the back of the spine opens. When you stand up, the back of the spine closes. So if you think about it, how can we keep the back of the spine open even when the patient's standing up? That's where this technology of interspinous devices came about. So this is the back of the spine. When the patient sits down, the back of the spine opens. When you stand up, it closes. So if you put a spacer between these spinous processes, interspinous device, you can maintain the space open, relieving the pressure from the nerves even when the patient's standing up. And the beautiful thing about this is when you put this device in and recreate what the patient does when they sit down, you don't have to remove any bone or soft tissues. So you can do this really minimally invasively, and especially with this new device that just got FDA approved last year, we're able to actually percutaneously, meaning with a tiny little incision in the back of the spine, this is again the side view of the spine, showing you how we can put this device that's as big as a quarter, even when you're expanding it, putting it percutaneous like this between the spine and expanding it. So these 2 wings that you see expanded here are collapsed. You put this between the spinous processes under live x-ray, and you expand, and you turn this screw right here, and then that expands these wings, keeping the spinous processes apart, relieving the pressure from the nerves. And it's a very exciting new technology for treatment of lumbar stenosis, which is such a common problem that we have in the United States. I have a vast experience treating patients with these interspinous devices over the last 10 years, the previous device that I've used, the X-Stop. The same concept happens in the neck, where the disc collapses and the nerves that are exiting on the side of the neck can be pinched. And when this happens in the neck, you have shooting pain down the arms, as this depiction shows you here, where the pain could be, depending on what level is affected, anywhere in the arm. And when you have that pain, tilting the neck back causes further compression on the nerve and more pain down the arm. That's called the Sperling sign. And in some patients whose disc either on the side or they don't have any pressure on the spinal cord, and their main problem is this shooting pain down the arm, we have an opportunity to free up that level by just putting a wedge between the bones. And I'll show you what that wedge looks like. So this is the disc in the neck. These are the 2 vertebrae. One is here, one is here, and the nerve exits in this hole. And the space is wedged here with this device, which on the cartoon image they've painted it yellow for better visualization, but in actuality it looks like this. It's a tiny little image, I'll show you an x-ray of it, that we, again using tiny little incision under live x-ray, we're able to put this between the bones and separate the bones apart, relieving the pressure from the nerves. Another exciting technology that I've been using for patients. And these patients go home the same day or the next day with, again, no incision, no need for stripping the muscles away so we can see the anatomy, because we're really doing this decompression or taking the pressure off the nerves indirectly, minimally invasively. There's a side view of the neck with the nerves being here, with this thing wedging, D-tracts wedging the vertebra apart from each other. And finally, I wanted to talk to you about another common complaint that you see in patients with back pain. It's been estimated that 90+% of Americans will suffer from back pain at some point in their lifetime. Most of those patients don't come to our offices because their medical doctors or general practitioners are treating them, or even they don't even go to the general doctor. Most often, the pain goes away by itself. But in some cases, these back pain patients can have chronic pain where the pain continues. Some of these patients have disc herniations that we talked about earlier. But in 20% of these patients who have back pain, I've written an article on CNN about this, 20% of these patients will be suffering from not spine, even though their pain is in the lower back, but they're suffering from sacroiliac joint dysfunction. So the spine, the lumbar spine sits on top of what's called the sacrum, or the bottom part of the spine. Here's the tailbone, the spine sits on top of it, but the pain could be in this general area, which could be mistaken for low back pain, but in fact, 20% of these patients are suffering from the pain from the sacroiliac joint. Most of these patients, again, don't need surgery, but the important thing is that the diagnosis has to be done correctly, because if a patient with sacroiliitis gets epidurals in their back or gets treatment for their lower back, their sacroiliitis is not going to get better. So when the diagnosis is made, then the proper treatment can be initiated. In patients who fail non-surgical management, where they have not responded to injections long-term or belts or physical therapy that we prescribe for patients, they can be a candidate for sacroiliac fusion. Sacroiliac fusion was not being performed, for decades because the surgery itself was so invasive that it was not worth it, because the patient would then be suffering from the consequences of a big surgery or big operation with the risks involved. For the last several years, we have had the opportunity to treat these patients with less invasive techniques. So these are rods that you can actually insert between the joint. Here's the joint. You put these rods through a small incision on the side of the pelvis, and under live x-ray, we can place these devices crossing the SI joint, and the material of this device is titanium, which is the same material that's used for total hip replacement. So it's not an unknown type of an implant, but we place it again through a small stab incision through the SI joint, stabilizing that SI joint, ridding the patient of that SI pain. So another exciting new technology. And this is a X-ray showing you those three rods going through going across the SI joint, stabilizing that joint. I thank you for your attention. It's been really a pleasure having this web discussion with you. Hopefully it'll be a discussion. I know that many of you have sent us some questions. At this point, if you haven't sent questions and you have questions, please use the hashtag UCLAMDChat to send us your question, but I'm going to go ahead and start answering some of your questions. Again, thank you for your attention. My name is Dr. Nick Shamie. I'm at UCLA. Thank you. So one of the questions is a great question and a very general question, which says, I have been undergoing physical therapy, but I'm still in pain. When should I begin to consider spinal surgery? Well, obviously this doesn't give us any details about where the pain is, but if I were to answer this in a general sense, I would tell you you need to really seek expert opinion. My recommendation to you is to go see a spine specialist, whether it be a non-surgeon or a surgeon in the area of spine, who can properly diagnose you to perhaps give you some direction on what the next steps would be. So I think seeking an opinion from an expert is my answer to your question. The other question is, how should I prepare for cervical fusion surgery? I think that's a very important discussion to have with the surgeon who's going to be performing the spine surgery. There are numerous types of cervical spine surgery or the neck spinal surgery that you can have. Depending on if it's a big surgery or a small surgery, you need to have different types of preparation. But oftentimes, when you go to see your surgeon for the first time and the surgery is recommended, patients, after they hear about their diagnosis, they tune out because they're so worried about what's going to happen in the next few months. So it's important, if you're one of those patients, to make another appointment and go see your surgeon and write down the questions that you have beforehand. So when you go in the room with them, you can ask those questions and get them answered before the surgery. Another question is, which kind of spine surgery has the highest success rate? That's a great question, but the answer is really dependent on the diagnosis and proper diagnosis. Because if you can have a spine surgery that is very successful in your friend, family member, or your neighbor, but if you have a spine issue, that would be a completely wrong surgery for you. So it's a very important thing to have a right diagnosis. And if I were to tell you the kind of surgeries that are most successful for us when we have made the right diagnosis, is probably the decompression surgeries that we do. Whether it be a disc herniation in the lower back or a disc herniation in the neck, those surgeries generally give us the best results and happiest patients. Another question that has come in is, do exercise or mind-body practices have any significant effect on spinal issues? Absolutely. The big powerhouse that we have is our head and our brain. And obviously, having imbalance with emotions or events in your life could have a significantly negative impact on your neck and your lower back. In fact, one of the common sayings that we all use in our everyday lives is pain in the neck. When bad things happen, we refer to them as pain in the neck. Or some people who we don't have good relationship with, we call them pain in the neck, because emotional issues do manifest themselves in our neck and lower back. So it's really important as a surgeon to make sure that we sift out those problems and not recommend surgery to a patient who's going through a tremendous stress in their life or having a major loss. I typically like to wait until those issues are resolved and addressed before I recommend a patient to have a major surgery. So absolutely, those psychological issues can have a negative impact on recovery and even on the preoperative or pre-treatment phases of treatment. I think at this point we have run out of time, I believe, and it's been really a pleasure being with you on this web. I hope to garner some more questions once we're off air, and we'll be happy to answer those questions in a timely fashion. Thank you again for your attention.